Dr. Fryer and I are extremely excited to share one of the most impactful initiatives the Florida Quality Collaborative has led to date, and that's the Postpartum Access and Continuity of Care Initiative, or PAC. PAC was actually our post-pandemic initiative. At the time, we knew that we needed to focus on something meaningful but manageable. It was post-pandemic, our teams were exhausted and needed that collaborative work to get back together. And so we wanted something that would be really, really meaningful for them and would make a difference for mothers and families. When we kicked it off, we really saw that PAC resonated with our teams. And I say that because we kicked off the initiative in October 2022. And by January 2023, when we started collecting data, many of our hospitals had already implemented several of the tools that we had developed. And there was huge momentum. It was very, very remarkable. So today we are presenting to you a project that is very close to our hearts, and seeing your updates, you have already done so much of the work. So we are more than happy to share some of the development of the tools and the reasoning behind them. We'll start with a brief overview of the ARPQC, then we will share some state data that helped draft the tools and the initiative itself. And then finally, we'll talk about some of the challenges and the gains that we have had in the initiative. There will be time for questions, as said before, towards the end. So if you have questions throughout, please don't hesitate to drop them in the chat, or we'll just address them at the end. So the FPQC has visions and values very similar to other PQCs. In Florida, we want all of our Florida's mothers, infants, and families to have the best health outcomes possible through receiving respectful, high-quality, evidence-based perinatal care. We are data-driven, population-based, evidence-based, respect-centered, and value-added. We are very blessed to have wonderful partners and funders. The major perinatal organizations in the state sit at our table in our advisory committees, the steering committees, and we are guided by a collaborative effort. So for PAC, we actually have 104 maternity hospitals in the state at the time that we launched PAC, and 75 of those hospitals participated in the PAC initiative. That's 72% of maternity hospitals taking care of 82% of births. So PAC had widespread statewide impact, and that was a huge gain for us. Before we started, we knew that 42 hospitals had some postpartum efforts in the past, but most of them were focused on education. You can see that on the right. Only 6 had actually worked on the scheduling early postpartum visits or in assessing high-risk postpartum patients. So we knew that there was a lot of opportunity. Using the state data, we also know that you can see the line in orange. That is our pregnancy-related deaths in the state. And in green, you can see the postpartum discharge deaths. So depending on the year, it can be a third to a half, or the deaths in the state actually happen after women have given birth and have been discharged from the hospital. So again, a huge, huge time of vulnerability that we can make changes. Again, with our state data, we looked at the underlying causes of death and identified the leading causes of death. So for us, you can see that during the postpartum discharge period, that for us is the causes of death, leading causes of death are cardiomyopathy, cardiovascular disease, thromboembolism, infection, CVA, hypertension, and depression. And I bring this up because one of the tools that we're going to talk about today that was developed by Dr. Fryer and a big work group, the maternal discharge risk assessment, the conditions that were selected are based on these leading causes of death. Right? We wanted to make sure that we addressed every single one of those leading causes of death in the state and provided recommendations that were aligned with ACOG recommendations for treatment. We also know that these affections affect women disproportionately. We know that women that have Medicaid, that are obese, are 35 years or older, and non-Hispanic Black are disproportionately impacted. And that is one of the big advantages of quality improvement. Once you standardize care, those gaps tend to diminish, and that's one of the goals of the initiative as well. We also know that most of these deaths in the postpartum period are preventable. For our state, a third were substantially preventable, and a third were moderately preventable. A third were not preventable. But that means that 2/3 of those deaths, we could have done something to change the outcome. So that is a big, big driver in our state. Now, when we look at pregnancy-associated deaths in the state, the leading cause of death is drug-related deaths. And that has changed a lot through the years for Florida. In 2010, you can see the line in orange, had a rate of around 12 deaths per 100,000 live births. And through the years, that has gone up. And then in 2020, we had the highest peak. We know that drug-related deaths in the state are the leading cause of death, of pregnancy-associated death. And when we look at the number of women that die of drug-related deaths, it's actually more than all pregnancy complications together, right? It's a very big deal. More than 75% of these patients actually die after discharge from delivery. So again, that postpartum period after discharge being the vulnerable period. And more likely to have a prior standalone ER visit. We know that these women went to the ED at some point before they died. And so there was a time where there could have been intervention before their death, and unfortunately there wasn't. And so we know that this is another big problem in the state. And again, this is one of the reasons why you will see substance use disorder as one of the conditions in the maternal discharge risk assessment that we implemented as part of the PAC initiative. You have been implemented a postpartum bundle, so this is not news for you, but 50% of postpartum strokes happen within 10 days. 20% of women discontinue breastfeeding before the first 6 weeks. Up to 40% of women do not attend the 6-week postpartum visit. And there's actually evidence that if you bring women to an early postpartum visit, they are more likely to come back at the 6-week postpartum visit. So that continuity of care is very, very important. And then we also know that 1 in 5 women experience a postpartum mental health disorder and require additional support. And so all of that is some of the reasons why we chose to focus on PAC, and it was part of the background, right, of why it was so successful, because we identified that there was such a huge and important need to do work in that area. We also know that women desire improved postpartum care. There are several qualitative studies that point to women's lack of satisfaction with postpartum care compared to maternal care. Women note a steep drop-off in care in the early postpartum period. They're not seen for a very long time. And women report wanting additional early postpartum care. So that is what we set out to do. The ACO committee recommendation provides a lot of feedback on what needs to be done to optimize and refine postpartum care. One of the recommendations is that all women should ideally contact with maternal care provider within the first 3 weeks postpartum. For us, for Florida, we actually put our goal to set up that early postpartum visit within 2 weeks. So a little earlier than the ACOG recommendation, but we wanted to have that higher goal to have women seen earlier. And we actually call it post-birth health check. So you will see that name. It's just the early postpartum visit, but we changed it a little bit so it would be more patient-facing, easier to understand for our patients. So in PAC, using the AIM bundle and the ACOG recommendation and everything else that we just discussed, we came up with 2 aims and 3 key drivers. So our aims were to increase the percent of patients with a 2-week postpartum visit prior to discharge by 20%, and to increase patient postpartum medication also by 20%. Our key drivers are 3. You see them there. The first one is to have a process for maternal discharge risk screening and arranging those early postpartum visits, to have comprehensive postpartum patient discharge education, and to have clinician postpartum engagement and education. Our bundle is large, so we have chosen a few for each driver today, and we're going to go through them just to share some of the higher implemented tools. So in the first section, we said that we want to have those processes for maternal discharge risk screening in place and arranging those early postpartum visits. We ask our hospitals to work through a process flow to schedule those early postpartum visits. We asked our hospitals to conduct a postpartum discharge assessment prior to discharge, and that is taking the vital signs and having action if there was anything abnormal in the vital signs. And Dr. Fryer will talk to you more about it, and we'll share some of the results in a second. And there was also a goal to implement universal maternal discharge risk screening for postpartum care and to schedule any needed follow-up care or connections to the community if needed based on that maternal discharge risk screening. So this is just a flowchart of the discharge process. And you can see that those were the steps that our teams were going through. They made sure to validate the maternal discharge risk assessment. They had to place orders for those maternal risks, if there were any. They had to counsel patients on the benefits of the early postpartum visit and give out educational materials. That was key because going through all the effort to schedule those visits, we needed to make sure that patients saw the importance of attending those visits. On the fourth item, you can see that the teams had to schedule the two-week post-birth health check or earlier if needed and complete the referrals and add to the discharge paperwork. On the fifth step, teams had to perform the postpartum discharge assessment just prior to discharge, and those are the vital signs. Again, Dr. Fryer will talk to you about it in a second. And then finally, to document counseling, education, and postpartum care plan in the chart. So as you can see, this is just the postpartum workflow close to discharge that every single patient needed to have in Florida to get that improvement that we were looking for. I talked about our aim being that 2-week postpartum visit being scheduled prior to discharge. These are our results. We started at 34%, and you can see something that is nice to see in quality improvement, month to month, sustained improvement. And so every single month we saw a couple of points going up and up and up and up. And so, we were able to attain our goal very easily. And in fact, we went up 28 percentage points by the end of the initiative in May 2023. We have sustained our gains. We invite our PAC hospitals to continue submitting data for an additional 3 years. And just so we can see what's happening, right? Once we close the active phase, we want to make sure to see what is happening at the hospitals. And we have been able to see a sustained improvement from where we left off. So I've said that we were going to talk about 2 important tools today, the maternal discharge risk assessment and the postpartum discharge assessment. So let's start with the maternal discharge risk assessment. This is a list of 7 conditions. The first 4 are screenings for the leading causes of pregnancy-related deaths, something I mentioned before as well. So remember, the first one is all the hypertensive disorders in pregnancy. So we were asking if patients were diagnosed with chronic hypertension, gestational hypertension, preeclampsia, eclampsia, maternal heart disease, or related conditions. And then we provided the guidance of what needed to be done if the patient is screened positive for any of those. So they had to schedule the blood pressure check in 2 to 3 days and the appointment with the OB or PCP in 1 to 2 weeks. If they say yes to maternal heart disease, they had to schedule the appointment with the cardiologist in 1 to 2 weeks. In the second condition, we talk about the history of venous thromboembolism. And the recommendation here is if the patient had any history or had any of those issues, they needed to have 6 weeks of medication for anticoagulation in hand prior to discharge. On the third condition, that is based on, the information we shared about infection being one of the leading causes of death in the state. So we asked, did the patient have a C-section or 3rd or 4th degree vaginal laceration? And if so, was she scheduled for a 1 to 2 week incision check with an OB? The fourth one is related to substance use disorder or being screened positive with an evidence-based verbal screening tool. So, if yes, you needed to perform this BERT and then refer to MAT or MOED. We worked on providing naloxone kits for most of the hospitals or providing at least a prescription and having an OB follow-up in 1 to 2 weeks. So our teams had to screen for all these questions, but that was not enough to say that they completed the maternal risk assessment. They have to have followed their recommendations under each one of those conditions to say that they completed it. So if they didn't follow up on the recommendations, they had to mark this tool as not completed, right? Because what we needed to document was actually if the action was prompted and completed. So that is an important caveat there. We did have 7 conditions, right? So the last 3 are actually questions, quick 1-question screeners for 3 issues. The first one, intimate partner violence. So the question was, do you feel unsafe at home? Is there a partner from a relationship who's making you feel unsafe? And if so, those patients needed to be referred to a case manager or social worker for assessment prior to discharge. The second question is related to mental health. So, over the last 2 weeks, have you felt down, depressed, hopeless, have little interest in doing things, or have a history of mood or anxiety disorder? If yes, then they need to be screened with an Edinburgh postpartum depression scale, contact the OB provider, and schedule a follow-up for mood check-in in 1 to 2 weeks. And if appropriate, then do a consult with a psych. Psych consult prior to discharge. And then the last one is if patients had any SDOH, is social determinants of health, positive screening, or if they needed additional community resources. So you can see there the screener is, can I connect you to additional community resources? And if yes, again, they needed to be referred to a social worker, to Healthy Start, Medicaid case manager, or the hospital finance counselor, depending on the need. While we were working on PAC, ARPQC received a small grant from United Healthcare, and we contracted with Healthy Start. So Healthy Start worked with our hospitals to update local directories for community resources. Because, if they identified the need, we wanted to make sure that our hospitals had the most updated contact information for local community resources so they could appropriately contact those patients to them. And these are our results for the implementation of the maternal discharge risk screening. So again, this is across 75 hospitals. The vast majority of them implemented the tool. At the beginning, they used the paper form that we provided, the PDF that had little check marks on the side. So pen and paper, but many of them quickly worked on EHR implementation because we know that if those are implemented in the EHR, there's better outcomes for the sustainability of the tool. And so at the beginning, we started with 26% of patients having the risk assessment completed. And towards the end, you see that the vast majority of our patients had the risk assessment completed all the way to 85%. And that luckily has been sustained as well. Okay, Dr. Fryer.
Yeah, so I'll pick up where she left off. So we called it the postpartum discharge assessment, was our vital signs check. This is just the post-discharge vital signs check. So we ended up setting these thresholds. If somebody did not meet, then they would need to alert the provider and hold for discharge. So elevated blood pressure, elevated pulse, fever, or elevated respiratory rate. Any of these, if they happened, then they would hold for discharge. We did give hospitals kind of a window of up to 4 hours to do this prior to the discharge, like them actually being discharged from the hospital, but we ideally wanted them to be done within 2 hours of discharge. So every hospital did implement this slightly differently. And of course, we know that sometimes they get their discharge paperwork and they sit there and are waiting for a ride for 6 hours. So we didn't count that. We were kind of like, when they get their discharge paperwork and they're officially out of the computer system and officially discharged was kind of when we started the clock. And so we wanted to make sure they had a vital signs check within 2 to 4, ideally 2 hours prior to discharge. This can be a little tricky when you don't know when somebody's going out the door. So that's why we kind of set that clock at that time. What we were really trying to go for is, a lot of times they just have Q shift vitals whenever they come in at that point, especially if they're an uncomplicated vaginal delivery, you're not doing vital signs every 4 hours or anything like that. So we really wanted to make sure that if they only had like a 6 a.m., 7 a.m., or 8 a.m. blood pressure check and they didn't leave till 2 in the afternoon, that we did check that prior to when they were going home. So that was really the goal of that one. So as I said, each hospital kind of had ways to customize that, but a lot of them were also able to put hard stops in their discharge EMRs. If they had Epic or others, that would let them put that in there so that when they did the discharge flow sheet or flow in the EMR, that it would stop and have them do that prior to discharge. And we did find several saves that we'll talk about in a second. So we'll go to the next slide where we have how that looked as far as the outcomes. So Um, these again show a month-to-month increase and sustainability for that post-discharge vital signs check. So we ended up starting off pretty low, lower than I think probably some of us expected, 38%, but we were able to get up into the to the 80s. So we didn't see month-to-month improvement with that, which was awesome. And then, as I also mentioned, we had some patients saved. So we had some great stories from hospitals. So we'll just talk about just one from one of our West Florida hospitals. So um, they were on the ball and trying to do it within 1 hour, which is amazing. So they set a nice high gold standard. And they had a patient who they were getting ready to discharge, but her vitals fell outside the parameters. So she ended up staying. She, of course, was not happy, which we know this happens a lot. They want to go home with their baby, but their vital signs are not good. So you end up having to keep them. And she was actually considering leaving against medical advice. But unfortunately, overnight, fortunately, she was in the hospital, but unfortunately, overnight her condition worsened and she had a rapid response, ended up in the ICU with admission and intubation, and because of her elevated blood pressures. So, and if she had not been caught, those elevated blood pressures prior to discharge, she easily could have gone home and had a stroke or had other, profound complications. So, following that new protocol likely saved this mother's life, and from definitely from more morbidity. So we had multiple stories of this all over. Even myself at the hospital where I'm working at most recently had one similar thing. Her blood pressure just kept climbing and she didn't want to stay. And I was like, we need to keep you. And then they end up, staying, and then they end up with severe preeclampsia on magnesium and needing to stay for blood pressure titration. So we found this, you can get some pushback from your nursing team and they're like, oh, but I just want to send her home, and why? But you really can catch, because the blood pressure especially tends to be the one that, at least in my clinical practice, tends to get the one that gets caught. But their blood pressure peaks 7 to 10 days postpartum. So sometimes you catch it on that uptick. Or it may be somebody that, it's not super high, but you want to start them on medicine before they go home, keep them for a few more hours, make sure they're okay, and send them home on medicine. And then so that you can keep a close eye on them outpatient, but you catch that preeclampsia, get it treated before it becomes a severe problem. And then they end up, readmitted. So it's a great time to prevent some readmissions. So going next, we had some education on our post-birth health check. So we did have some tailored patient-facing information that we gave out as well. So this is something we developed to show patients why that they would have that 2-week post-birth health check or postpartum check, as well as the 6-week follow-up visit. Our patient advisors really strongly did not want to use postpartum because they associate that with postpartum depression. So that's why we use post-birth, just so you know, but it is synonymous if you see it on our slides. So it kind of talks about why we did that check, why it's important, what you should expect, and then when the visit is, and then you can put it on there if they had it. So we had a poster form of this, as well as one that they could put fill out for the patient if they'd like. So everybody kind of incorporated that a little differently, some of them electronically, some of them posters, however they would like to do it. Each hospital kind of customized that. The other thing we did, which was a little different, we didn't use the bands like you guys are using. We actually had something slightly different, which was called the post-birth wallet card, which we gave out. This was similar to the bands, and the idea of if somebody came back to the hospital, either to an ER, freestanding ER, et cetera, that they would have something to show the provider there that would let them know that they are postpartum, and that when they delivered and what their complications were, if they had any. Especially with their OB provider. So if they needed to get in touch with them, especially for those freestanding ERs, which do not have OB providers there. So this was something that they could fill out. A lot of times we had patients take pictures of it on their phone because they lose the card, but the idea was to put it in their wallet. So this was also something some hospitals kind of customized this to doing, actually giving patients their discharge summary, similar to what a lot of the infants get their discharge summary to take to their pediatrician. So some of them also did that as give the patient their full note. But this is what we did for the wallet cards. Other patient information that we handed out, these are, freely available, and a lot of you guys may be using this. The Hear Her campaign from the CDC, we use that for some of our post-birth warning signs and when to come back to the ER. These are available in so many different languages, which was lovely if you have a patient who has a language that is not, in Florida, most common is English, Spanish, and Haitian Creole. So we generally have everything in that, but if it's beyond those languages, these would allow us to have that in multiple languages. And then we also use the A1 post-birth warning signs, which I think a lot of hospitals had already implemented, which was fantastic. And then we encouraged that. So I use this personally, this one in my practices. This is my favorite one. I was just teaching my residents the other day about this. So this is also available in multiple languages, freely available. I have copies of this in English, Spanish, and Creole in my office. But this one also gives a great one-pager for patients to know when to call 911 and when to call their health provider. Also, for those who were not English speaking, a lot of times I'll write on there where they gave birth, who their doctor is, and information that you can customize this to your facility. Also, this is available on magnets, which some of our hospitals really loved because it would be the idea of them put it on their fridge. And there's multiple different ways people use this electronically. They have licensing you can use and customize it to your hospital as well. So as we looked at our results for how we did for these education prior to discharge, we did do several different education pieces. So we kept track of each one. The first top dots, our light blue dots, are our postpartum warning signs. We were already having great success with that prior to the initiative and continued that. So that was one that we noticed that hospitals had already been doing prior to the initiative. Probably the most was that postpartum warning signs. The benefits, educating on the benefits of the early postpartum visit did go up. That was a newer tool, so that was something that was new for all the hospital teams. And then also education on family planning, birth spacing. We did have some Catholic hospitals that were involved, so we did have some that we had to customize some of their pieces, but we did have good success in increasing our discussion of family planning with patients as well. So we also did several things to really try to pull in engagement with our clinicians in the office. I'm a provider who works within the office and the hospital, so getting those two to talk to each other can also be tricky, especially if you're the hospital and you're trying to work with private offices or having multiple offices to work with. So we did work with our ACOG clinician group in Florida. We are our own District 12, so that encompasses all of Florida. We have great ties with them and actually had their chair and vice chair on our team. So they did send out a letter to all of our outpatient teams that explained why we were doing this initiative, what the rationale was behind it, the ACOG guidelines behind it, and some of the billing practices as well, which I'll go into. So this really was to kind of try to get some of that pull and official piece from the office clinicians to try to really get some buy-in and help. So really trying to have physicians reach out to physicians, because a lot of times that tends to be more effective. And also having the ACOG seal of approval on it from a Florida District 12 also was very helpful. So we also developed a postpartum mortality brief for providers. This also was a one-pager. We handed this out at our ACOG District 12 meeting. That's yearly. So that shows what the data is behind it, why we are doing this. And there was a flip side that also showed the ACOG guidelines. But again, this was provider facing. And, we also had webinars, slide decks, everything. But again, trying to pull in some of that clinician engagement, especially for the office clinicians, to get the buy-in, because you are trying to have patients come in more often. You're trying to open up a slot. Do you have the slots available? Are you overwhelming the clinics? And again, being post-COVID, this was always a little bit of a challenge. We also developed some office both for office clinicians as well as for patient facing, to talk about what should be done at that 2-week visit. So what you should consult the patient on. We use the B's, as we call them, so the blues, bonding, breastfeeding, bleeding, etc., as you can see there. That we used as kind of a fun mnemonics. We had posters of these that they could use, as well as one for patients that they could write their questions or if things they wanted to talk to the physician about to kind of help make this a smooth visit. You can have them fill out what they would like to talk about. And on the flip side, they had resources that were statewide resources that they could use for all of those. So that was one piece we used for providers. And then we also had billing and coding. So this was a big, big deal in our clinician facing, and something that I spent a very long time in the weeds with billing, more than I ever wanted to know about billing for postpartum visits. So this was one of our biggest hurdles for us, was trying to get these scheduled. So the billing and coding piece was very critical. So we actually came out with a billing and coding suggestion sheet about how they could bill outside of the global package. In other words, just ways that they could get extra reimbursement for that post-birth health check, adding that 2-week post-birth health check. And different offices created different ways that they would bill for it. So there's several different suggestions here. And so those were, they could bill outside of the global obstetrical package. If there was a complication or issue, they could end the global package early. Again, they'd have to work with their payers on some of these, or they scheduled a 6-week postpartum visit after the global period. So it would be weeks 7 or 8, whenever the global period ended. So then the 2-week one would count in the global and the 6-week would not. So some also were billing those as annual exams. So there was various ways to work with that. So that was one piece. Now, the other piece we had after COVID was capacity, because we had issues with our clinicians on the outpatient not having a way to fit these in. This was in my office when I was working the closest with. This was their biggest. They had capacity issues in one clinic, and then I had another clinic that didn't have the capacity issues. So this was very important for those. So as you get trying to make these scheduled visits, we had several different options. So one was starting a nurse-driven protocol, which I'll show you in a minute, where it's really a lot of these visits are seen by nursing or triaged by nursing, with provider supervision, but not having to put them on the classic clinic schedule. There's also a way, which I'll show you, to trade an antepartum visit for a postpartum visit. This is especially even more true now with the newest ACOG guidelines about customizing the prenatal care visits. So it gives you more flexibility. There is now ACOG guidelines around that, following the Michigan model. And the other option, which a lot of some of the private clinics loved, was telehealth. They would do telehealth check-ins as long as the patient had a home blood pressure cuff. And I even had some nursing visits with telehealth. So those were all options. So going on to that nurse-driven protocol, just briefly. So if they didn't have any C-section or severe laceration, or they weren't considered high risk from a medical standpoint, then they would go on the nurse's schedule. And then they could be either telehealth or in person, depending on if they had hypertensive disorders or pregnancy. And then if they were high risk or had a condition where we needed to see them for an incision check, like in person, then we would have them be on the provider visit. So this is how we customize for our clinic. Obviously, every clinic can customize that to be different, but we really found some great success in our clinic with helping with that capacity, because we had loss of physicians, so capacity was a huge issue in that particular clinic. You can go on to our next slide. And then the other piece was trading an antepartum visit for a postpartum visit. So there is, and I pulled this straight from the Michigan care pathway, there is kind of a high intensity versus a low intensity in-person visits schedule. So you can basically trade one of your antepartum visits. A lot of times people will do somewhere around like the 30-week visit, or one of your very end, like 37, 38, combine that one, and then trade that for a postpartum visit. So you end up with the same number of clinician visits without having to to increase that. So that was another piece that we found great success with. So as we go to the next, we have one more patient story. And this was another hospital that had a patient who came in after having a normal vaginal birth, no risk factors. She had her 2-week clinic visit, and then she came in and was found to be very depressed, overwhelmed, had feelings of suicide, of harming herself. So she was readmitted to the hospital, and admission to a psychiatric care as needed for her severe postpartum depression. But that was another kind of save from the 2-week postpartum visit, where you wouldn't have normally seen this patient until 6 weeks, and then she could have been much more depressed and worse off and not gotten any treatment in that time period, and may have ended up back in the ER with something really acute happening. So this was a way that they were able to get her to the care she needed, while avoiding some of that trauma for the family and everything. So this is another great save from one of our hospitals. And I believe that is to the end of our slides. So these FPQC information is, so if you get in touch with us, we are fpqc@usf.edu. There's our information as far as our website. We do have a lot of the materials I showed are still there and still up. They're just in a toolbox there.